Good morning and welcome to Health Talk, sponsored by Mon General Hospital. This program is designed to provide education on vital health topics to help you take charge of your health. You'll also be introduced to Mon General's committed physicians, allied healthcare professionals, and quality programs and services. And now, here are your Health Talk hosts, Kay Murray and Jim Stallings.
Dave Wilson in with Kay Murray on Healthline this morning. Good morning, Dave.
Good morning, Kay. How are you today?
Hey, we're doing well, and this is a subject that, maybe some men will shy away from, but not you.
Absolutely not. We have some exciting news coming to Morgantown.
We do.
In regards to the OBGYN and oncology. And joining us this morning here in studio is Dr. Bill McBee. Good morning, Dr. McBee.
Good morning.
Morning.
Let me turn your mic on, try that again. Good morning, Dr. McBee.
Good morning, guys.
And joining us, and she's going to be coming to Morgantown, and it's really a big grab for the Morgantown medical community, is Dr. Jamie Lesnock. Good morning, Dr. Lesnock. Lesnock, I got your name backwards. Good morning.
That's okay.
I'm
Hi.
sorry about that.
No problem.
Now, Dr. Lesnock, you have been recruited by some big dogs. This is like landing a five-star football recruit here in town. You were recruited to go to maybe Johns Hopkins or the Cleveland Clinic, but chose Morgantown. What attracted you to Morgantown and the Monongalia County community?
Well, first and foremost, as some people may know, I trained with Billy in fellowship, and I'm just finishing up my fellowship, and we really enjoyed working together, and so the opportunity to work with him was one of the major factors. But also it's close to my family. I grew up in Washington, PA, where most of my family still lives, and my husband's family is close by as well. So it was an easy choice at that point.
And, of course, Dr. McBee's in the studio, and it's so hard for one to kind of brag about herself, but what does this mean, of course, for Mon General Hospital?
I mean, I think it's a really big deal. I think it's very hard for anybody to recruit GYN oncologists just because they're kind of few and far between. There are probably only 40 to 50 graduates in GYN oncology programs each year, so a lot of very big-name institutions have a very difficult time recruiting somebody. And certainly smaller places like Morgantown, it's almost impossible. So to have two GYN oncologists is just remarkable.
And, of course, they're coming into Mon General Hospital. Is that because of the way Morgantown is growing that we do need to add another oncologist?
I think it's the way Morgantown's growing. I think it's the way West Virginia's growing, and also certainly Mon General Hospital. I mean, they've done a lot of stuff over the past few years to really make it, in my opinion, a regional referral center. And certainly we're developing that for GYN oncology. And
I think, Dr. Lesnock, you talk about your specialty and what exactly you focus in on in your practice.
So we, mainly, obviously, in our name is gynecologic oncology, so that entails we take care of women with cancer of, the female genital tract, ovarian cancer, uterine cancer, cervical cancer, and some of the other rare subtypes. But I think also kind of embedded in our specialty is just that we have very intensive surgical training to be able to take care of, benign conditions, so women with endometriosis or large masses or things that, gynecologists that don't maybe see that very often maybe feel uncomfortable with. So we kind of have the opportunity to take care of the very kind of sick patients, but also patients that and women that have problems that, again, just their general OBGYN doctor maybe doesn't feel quite comfortable doing. And we, we have really just the more intense surgical training to deal with that.
We're going to get into a little bit more about the endometrial cancer, but before we do that, Dr. McBee, we talk about Dr. Lesnock coming back to Morgantown, and it must be rewarding for you as well, being from this area.
Oh, yeah, it's great on a lot of different levels. It's nice to see Morgantown, to have, in my opinion, two GYN oncologists working together. It's also great because Jamie's a great friend of mine, so it's going to be exciting to work with her again. And I'd just like to add one thing to what Jamie commented on too. That kind of one of the unique things about GYN oncology is the fact that we also administer all of our own chemotherapy. So we really take care of when somebody comes in with a GYN malignancy. Not only do we do the surgical management, we also do all the chemotherapy and most of the medical management for these patients as well, which is very different than really any other cancer specialty, such as colon or breast, where in my opinion, the care is somewhat fragmented. Not that it's any less, but it's certainly not done by one provider.
When we say endometrial cancer, is that what we're calling uterine cancer normally?
Yeah, I mean, endometrial cancer is a type of uterine cancer. There are other types of uterine cancer, but endometrial cancer is the most common type of uterine cancer.
Okay, Dr. Lesnock, kind of put it in layman's terms and explain what is endometrial cancer. Explain that to us.
So, I mean, in the simplest terms, it's, women, before they go through menopause, menstruate every month, which is basically the shedding of the lining of their uterus. And, after menopause, which is the most common time to get endometrial cancer, unfortunately, the lining of the uterus is where the cancer actually develops. And so it's one of the rare cancers that we treat that actually will present early. Women will actually have signs or symptoms of the disease early on in the disease, which allows us to intervene and have a pretty high cure rate for early onset of disease.
And Dr. McBee, who is at risk? The risk factors in getting uterine cancer, endometrial cancer?
The biggest risk factor for endometrial cancer is really patients that do not ovulate every month. Like Dr. Lesnock said, patients generally have a period every month, but patients who don't do that, sometimes they skip periods. Those patients are at risk of premenopausal endometrial cancer, and certainly obese patients or other confounding factors such as diabetes, hypertension make patients at increased risk.
Dr. Lesnock, are we going to know it? Are we going to feel it? Are we going to be uncomfortable? Will a woman understand that there's something going on in her body that just is not correct?
Yeah, about 90% of women will, like I said, present if it develops after they've gone through menopause, will develop bleeding, and that's kind of the most common presenting factor. And so any woman who has gone through the change, so to speak, and then all of a sudden sees some spotting, that is not normal in any arena. So they should, see their gynecologist, who would do the appropriate workup, which usually includes a biopsy. Those women who have not gone through menopause, even they often will see changes in their menstrual pattern. So like Dr. McBee mentioned, there might be either it spaces out and then all of a sudden they have very heavy bleeding, or all of a sudden instead of having a period every month, they're having some bleeding every 2 weeks. So it's like I said, it's one of those diseases where we have the opportunity to see the symptoms early and intervene.
The other thing to mention, too, is a lot of times in postmenopausal women, they don't present with frank bleeding like they had earlier in life. So a lot of times these women will have, a discharge that's just different than they've ever had before. And a lot of times, that is the kind of the shedding of the tumor. And it may be a little bit bloody, it may not be, but that's also something they should see their gynecologist
So
about.
age is a big factor here.
Age is a big factor.
And again, if you catch it early, as we do most cancers, do we have an opportunity to survive this cancer?
We do. The thing about endometrial cancer is there's really a couple different groups of endometrial cancer. The most common type are easily curable most of the time with surgery. However, there are some more aggressive subtypes that even with surgery and aggressive chemotherapy, unfortunately patients don't do as well.
We have squeezed in our first break of the show. More with Dr. Bill McBee and Dr. Jamie Lesnock coming up here on WAJR.
This is Mon General's Health Talk. If you have a health-related question, call us now at 304-296-0041.
Welcome back to Mon General Health Talk. Dave Wilson with Kay Murray. Joined in studio with Dr. Bill McBee, and on the phone is Dr. Jamie Lesnock. And I apologize that I've butchered your name twice now, Jamie. I'm sorry about
Wilson,
that.
Yours is Wilson, so we'll mess it up too.
Jamie, you've been doing some research. Tell us about the research you've been conducting and if you'll be continuing that once you get to Morgantown.
Yeah, so a lot of the research I've done as a fellow has focused on ovarian cancer specifically, and a specific population of patients or women who have a genetic susceptibility to ovarian cancer, and trying to define just, in physiology terms or why those women respond differently to chemotherapies and have different outcomes with their cancer. And one of the reasons to study them is just because we're hoping that there's something about them that is still applicable to the entire population of women with ovarian cancer, because only a couple % of women will actually have those genetic susceptibilities. So that's what a lot of my work has focused on, and I do hope to continue that, or plan to continue that, while I'm at Mon General. I have a lot of contacts still at McGee and through UPMC, and also Dr. McBee and I will have the opportunity to participate with. There's a national network of institutions that treat women with all types of GYN cancer called the GOG, which conducts the big trials, and these are the trials that help define how we treat women with different types of cancer, because Dr. McBee and I are not going to be able to treat enough women to know what the best chemotherapy is. And so when you take together all of these institutions, we have a better sense of what the best chemotherapies are, what the best surgeries to do are, et cetera. And so we have the opportunity to kind of work with McGee of UPMC to continue to enroll patients. So it benefits us, but also benefits our patients, that they have the opportunity to enroll in these trials that may not be available in other places.
So, Dr. McBee, these clinical trials could continue here?
Yeah, absolutely. I mean, the thing about GYN cancers is that they're rare. So no single institution can really do a worthwhile trial, because there's just not enough patients. So any trials that are really going to make a difference in treating women with GYN cancers have to be done on a national or even international level. And it's quite honestly, as long as you have the connections, it's just as easy to do in Morgantown as it is any other city.
Jamie, you mentioned ovarian cancer, and I want to ask you a little bit more about that, because it seems to be where a lot of your studies have been focusing. Has ovarian cancer been a cancer that's so hard to detect in the past?
That's exactly that's exactly the problem with ovarian cancer, that 75% of women that will be diagnosed with it will already have very advanced disease, and the main difference between ovarian and endometrial is there's not that one or two symptom that women will see. It's a lot of vague symptoms, abdominal bloating. They may have a little discomfort. They may notice changes in their appetite. They may not notice anything, quite honestly. And so it's kind of the unfortunate, one of the very unfortunate diseases we treat, that women just don't know they have something going on inside of them until it's advanced.
Right now, is it only through a blood draw that you can find that someone does have ovarian cancer? And do you see that changing in the future?
So right now, there's not officially a recommended screening tool for ovarian cancer. There is a blood test that we use for women who we already know have ovarian cancer. It's called the CA-125, but that's only approved for a screening test in a certain population of women. Those are the women I kind of mentioned earlier that have a genetic susceptibility. So we don't routinely actually use that blood test. I think, part of the studies I'm working on, again, in these large trials, but also we work with cell lines, so in the lab trying to grow cells that have ovarian cancer. So clearly my goal, and the goal of GYN oncologists, is to find that test that will, one day potentially be the screening test like the Pap test is for cervical cancer.
And Dr. McBee, we're talking about detection and prevention, but what kind of treatments are out there for women?
Treatments for ovarian cancer primarily consist of surgery and chemotherapy. Women who are able to undergo upfront surgery and were able to perform an adequate surgery, meaning removing all visible cancer, followed by chemotherapy, do better than other women. So certainly, Jamie and I both trained in a very, very aggressive surgical program, so I'm looking forward to operating with her, especially on bigger cases like women with advanced ovarian cancer. And we also trained at a place that is very aggressive about chemotherapy, and And primarily, in my opinion, that means intraperitoneal chemotherapy. So we give a lot of, or pretty much most patients, or almost all patients with ovarian cancer, chemotherapy into their abdomen in addition to chemotherapy into their vein. And multiple studies have shown that patients who are treated in this modality have much better survival outcomes.
Rather ovarian cancer or uterine cancer, if we go to Mon General Hospital and we see you, or if we see Dr. Lesnock, do you follow us from the beginning to the end? Can we have our chemo? Can everything be done right here in Morgantown?
Everything can be done in Morgantown, and I think that's the point to make too. I mean, there's really, I know several years ago, a lot of patients in this area were traveling to Pittsburgh or the East Coast for treatments for these conditions. There's really no reason to anymore. I mean, the treatments you would get in Morgantown are identical to the treatments you would get in Pittsburgh or Cleveland Clinic or Johns Hopkins.
More with Dr. Bill McBee and Dr. Jamie Lesnock coming up here on WAJR.
The doctors, the latest news and procedures. Your local health connection is Mon General's Health Talk. If you'd like to be on the show, call 304-296-0041.
Dave Wilson, K. Murray with you, and we're joined by Dr. Bill McBee and Dr. Jamie Lesnock, and we've been talking about OBGYN, oncology, cancer prevention, and treatments. And how do you stress, if you're a husband or a father, how do you stress to your wife or your daughter to go get checked out, it's peace of mind for us as well?
Yeah, I think the important thing is primarily just make sure you see your gynecologist every year, and also just report things that are different. So like Jamie mentioned earlier, a lot of the subtle signs of ovarian cancer are if you get full easier, if you have mild nausea, if you have some vague pelvic pain, maybe a little bit of rectal pressure, bladder pressure. All of these things that are just different should alert you to see your gynecologist or see your medical doctor so they could do other testing.
Can it spread? Can endometrial cancer spread quickly, or does it contain itself?
It can. Like we talked about earlier, there are different subtypes of endometrial cancer, and the majority of them, fortunately, stay contained within the uterus. And like Jamie said, they present with bleeding, and usually we can do surgery to remove the uterus before it's spread. But unfortunately, there are subtypes of endometrial cancer that, even in very early stages, spread quickly.
And once it's detected, do we immediately start into chemo, or are there drugs or other treatments that you can pursue?
For endometrial cancer, by far and away, almost all women have surgery first, and probably 90% of those women don't need any additional treatments after surgery, but additional treatments would include chemotherapy and radiation.
Well, Dr. Lesnock, we're almost out of time, but we will look forward to having you in the studio next time.
Oh, absolutely. Thank you for having me.
It's been a pleasure, and welcome to Morgantown, and we're so pleased to have you.
Thank you. Have a good day.
You too.
Dr. McBee, thanks for being on the show this morning.
Well, thank you, guys. I appreciate it.
Goes quickly, doesn't it?
It always does.
But just one quick word. If someone does see that they're having a problem, what would be their immediate reaction?
If they see that they're having a problem, my advice would be to see their primary gynecologist or their primary care physician. And those, especially in the Morgantown community and in the state of West Virginia, I mean, those individuals do a very, very good job of seeing which patients they need to treat there and which patients need to be referred on to somebody like Dr. Lesnock or myself.
Okay, thank you very much.
You're welcome.